So what comes to your mind when I say healthcare in India? So what's the one word that pops in your mind?
Privatization.
Okay, privatization. What else? High out of pocket expense. खर्चा बहुत है, महंगा है healthcare, वो तो है ही. और बताओ. Decentralization. Somebody said decentralization. Okay. The fact that it's decentralized or the fact it should be decentralized? It is decentralized. Okay. Low system capacity. Health is a state subject. ये हमने अपनी civics की book में पढ़ा था. Thanks for the revision. Okay. Anything else, Nikhil? Lack of doctors. Yeah, I think now we're going into a rabbit hole there of lack of everything in healthcare system, which is what it is. There is no doubt in that. So today we'll be discussing how can DPGs and DPI empower the healthcare system. So we know there are a lot of gaps currently in the healthcare system with respect to inefficiency, with respect to sharing of data. There are so many hospitals, so many healthcare centers, but who is holding them accountable, right? And if you talk about the insurance companies, let's not go into that direction, but the experience is terrible there in the whole healthcare finance system. So there are multiple challenges across the public healthcare system in India and also globally, but we'll be restricting our discussion today to India specifically. And we'll be exploring different dimensions, right from private healthcare to MIS and record management in big hospitals, to how our insurance systems can be seamless, to how we can ensure a better digitization in low resource hospitals and healthcare systems in remote areas where there is no internet, where everything is going offline. So how do you have like digitization there? And then we will also discuss how do we enable this entire digitization through a community approach. So we'll also touch upon that ये बना तो दिया था वाला tech system, but adopt करने वाले जो लोग हैं, are they at the level that they can adopt, and how can that be accelerated, the whole people side of angle here. So we'll be diving into different dimensions, and we have 5 speakers from different domains, different dimensions, and they'll be presenting here for 5 minutes. They'll give a lightning talk, and post that we'll have a short panel where you can all ask your questions, whatever may come to your mind while they're giving their presentation. So I would request if you can make notes of the questions, and then we can take it up in the end together. Great. So let's kickstart. Our first speaker is Dr. Mithun James. Mithun is a medical doctor turned engineer, passionate about bridging the gap between medicine and technology. He finds joy in architecting scalable solutions that improve patient outcome and empower care providers. Currently serving as a technical architect at Pyramid Swasthya, he is shaping the evolution of the Amrit platform to enhance public healthcare delivery. He will be taking us through the entire journey of Amrit, which is also on the pathway of becoming a DPG. So I would like to invite Dr. James to share his perspectives on this. Yes. So you have to just go here. I'll just make it full screen. Yes. Now you can just operate next.
Okay. Good afternoon, everyone. So I'm here to speak about Amrit and how Amrit is transforming India's primary healthcare. So the first question that will come to your mind is, what is Amrit? Amrit stands for Accessible Medical Records via Integrated Technologies. So Amrit is one of a kind health tech platform that Pyramid Swasthya has developed. And here what we are doing is that we are creating patient records in the form of electronic health records, which can be accessed in different service lines across Amrit and also beyond through various integrations with DPGs and DPI. So what we are trying to address here is that we are ensuring continuity of care in primary healthcare. So there are different workflows that Amrit manages, but what I can do here is that in the interest of time, I can speak about one workflow on how Amrit is enhancing primary healthcare. And for that, I'll take you to a rural part of Assam. Let's go through the journey of a pregnant woman. Let's call her Pratima, and how Amrit at various touch points is improving the healthcare delivery. So in general, the first touch point will be with an ASHA worker. An ASHA worker generally visits the pregnant woman, and what we have done is that we have given them a mobile application called Friendline Worker application. The mobile app is offline first, which means it completely works offline without operator coverage, without network, etc. And the application also has certain algorithms that can suggest if the pregnancy is a high risk or not. So the next step generally includes ASHA taking the person to a health and wellness center. By the way, all these images are AI generated. You will see some irregularities. So ASHA worker mobilizes Pratima and takes her to the health and wellness center. In health and wellness center, a community health officer can use the Amrit facility application, and it's a web application where what they can do is that they can just pull the record of Pratima by entering their mobile number or registration ID, and whatever ASHA had entered already will be present in the facility application. And what we have also done is that the facility application also integrates with various point of care testing devices. So they will be able to look at the fetal health and also vitals with various hardware integrations. And this will help us in quick and informed decision making also. Going forward, the CHO, what they also can do is that they will also facilitate a specialist consultation with eSanjeevani telehealth portal. So we have also integrated in such a way that there is through a simple button click they can navigate to eSanjeevani, and all the beneficiary data will also be present there, so that they don't have to enter it again. Going forward, from the RCH portal, we also receive all the details of the pregnant women, and from our early childhood development call center, which is again powered by Amrit, from there an agent calls Pratima, and starting from the pregnancy until her child is 2 years old, that's like we have 21 calls over a period of 1,000 days. We give her guidance on health, nutrition, and everything related to pregnancy. So here also the same beneficiary record that was created by ASHA comes into the flows into the early childhood development call center also. Going forward, at the time of delivery, they can go to a higher center for safe delivery, and whatever that we have collected, since we are also ABDM compliant, all the details can be pulled by a doctor from a higher facility also. So that's how the DPI integration is done. And now at any point, let's say if Pratima wants to get any additional help, we also run a 104 call center in different states. They can just call the 104 call center to get any health advice. So one of our agents picks up the call and then gives her the right advice. Sometimes it gets transferred to a medical officer sitting at the call center. We even have integration in such a way that the call can even be transferred to 108 if she's having an emergency. So this workflow is like one of the workflows that Amrit is addressing for primary healthcare. We do have different service lines, as we call them. We do have mobile medical units, we have telemedicine units, etc. So there are different products under the Amrit platform umbrella. And the key features will include that we are interoperable. The beneficiary records can be transferred between service lines. It's also ABDM compliant, so any other health HIMS platform can also pull the records from Amrit. We do have multilingual support that enables that any frontline ASHA worker or any frontline workers, we can localize it and give the applications in their hands. All the code is available on GitHub, and we have recently open sourced it. It is also built for population scale. We do comply with various clinical standards, and especially for the agents, we do have an inbuilt clinical decision support system which enables them to take the right decisions. So at the core of it, what we want to do is improve the primary healthcare, make it more affordable, equitable, and accessible. And there are three things that you are trying to do here. One is empowering the frontline workers with the right digital tools so that they get the right information at the right time to take the right decision. And for that, obviously, a robust data-driven governance is important so that the higher authorities can also look at the data-driven insights. And at the end, what we are trying to improve is better healthcare service delivery. Amrit has shown impact in the last 6 years. We have created more than 2 crore beneficiaries. We are deployed in more than 16 states in various different service lines and configurations. And you can see the numbers also. Going forward, that's it from about Amrit. Since it's a lightning talk, I haven't added more details. But do look at our GitHub. We have all the documentation, all the code, everything is open source. We are looking for contributors. In fact, we have had, I want to profusely thank C4GT for all the engagements with Parimal Swasthya. We have had contributors through DNP program. We also are looking for more community contributors. We are still in nascent stages of open source contribution, so you might see the certain documentation, everything is still work in progress, but do check out the repository. We are happy to get more contributors. Thank you.
Dr. Mithun is one of our star mentors, so if any of you is interested in contributing, please do. He's a very, very good mentor. Thank you so much for explaining the entire journey of the Amrit Digital Public Good. Moving on, the second talk we have is by Dr. Akhil Malhotra. Dr. Akhil Malhotra has been in the field of digital health for the last 9 years, spanning both government and private sectors. Currently working as a domain specialist at ThoughtWorks, he has experience working across the spectrum of product development, large-scale implementations, and digital health policy. His work emphasizes integrating technology in healthcare to enhance efficiency and accessibility. He will be talking about implementing a DPG in healthcare called Bhamni and how it works specifically in low-resource environments. Over to you, Dr. Akhil. Apologies for this projection screen is a little challenging. Okay, great. Yes, here you go.
Good afternoon, everyone. So this is a post-lunch session. Building up upon Dr. Mithun's narrative on the public healthcare and the primary healthcare, we work a little bit on the not the community scale, but on one level up, where the patients are referred to from the community. Right, so we work with the facilities that we call primary health centers, then community health centers, and all the way up to the referral hospitals. So Bhamni is basically a completely open source hospital information system. It has different flavors to it. It is totally modular, and you can have these. You can choose your modules and build it for small facilities. Like we have Bhamni Lite, one flavor, and Bhamni Standard, another flavor. Right. Bhamni Lite is basically for smaller facilities, single doctor clinics or primary health centers, and Bhamni Standard for larger hospitals, 100 bed and plus. Right. So with that context, the photographs that you see on the left, this is the problem that we started to solve, right? And we aim to get onto the other side, which the photographs you see on the right side, right? This is a big problem, right? Keeping records, sometimes the patients come in and they are unable to find the records in time, right? And the patients require urgent care, right? They come in emergency. So sometimes the records get spoiled, after all it's paper, right? So that's the problem that we wanted to solve. and we began at Jan Swasthya Sahyog, which is one of the NGO hospitals in rural Chhattisgarh. We began from there, and we built out a system which is now present in 50 plus countries, 500 plus implementations, and some of these implementations are done by large humanitarian NGOs like Medicines Sans Frontiers or Doctors Without Borders. They run Bamni in almost like 25 to 26 countries, right? And it is synced across all of the countries. Right. This is a map of our geographical spread across the world. Right. You will notice that we are not there in Europe, Western Europe, and North America because that's not what we built it for. And this is our spread in India. Right. I would say we are still in very nascent stages in the Indian context. We still have very few implementations, even though we started with Jan Swasthya Sahyog. Then we found that if we are solving problems for this NGO hospital, there might be similar NGO hospitals. So we found customers in Search in Gadchiroli district in Maharashtra. Then we found customers in Lok Biradari Prakalp, which is another NGO hospital in Maharashtra. And the journey ended up Bamni becoming a DPG in 2021. And one of the biggest achievements I would say is that when we learned that one organization called Tattva Foundation has actually implemented Bamni in 12 facilities in Nagaland, and we did not even know about that. Right? We got to know through through a news article that Bamni has been implemented there, and then we got in touch with them and got to know that this is for the National Health Mission NHM in Nagaland. Right? So that's something that we consider as a big win. Talking about accolades, we are a listed DPG. We are also on the Digital X catalog, right? And we recently also won the Future of Government Awards. That was in 2023. Right? Now, we are also one of the first open source hospital information systems to be ABDM compliant, right? And then, I'll come to the strategy. So I'll take a little bit more time, just maybe a minute more. Right. So what we did right was we partnered with the grassroots organizations while we were building the product, right? And that, helped us to learn a lot of lessons because ThoughtWorks being a core technology company, has never worked in such conditions, right? We were always building stuff for enterprise scale, but these are the challenges that we figured out. That there is challenge of internet connectivity, there is poor electricity, outdated hardware, and like not just limited to that, but even the workforce that we used to find in those areas. There were a lot of challenges with that, learning challenges because of the level of education, and then we had to train them from even started using simple computers. So we used to train them on Facebook first. That you have your Facebook account, learn it, and then build a system which a person who just knows Facebook can use, right? So it should be that intuitive. So we started learning from those things, right? And lessons learned, the low resource environments are even more challenging than enterprise scale, right? And the best strategy is to choose your customers when you are building this, this in this kind of an environment. And another big lesson is that without local partners, you cannot thrive in that space. Tech for Good cannot survive without local partners, and without building an ecosystem, you just cannot survive, right? So what we did right was three things. We understood the local context. We built with the people. So this is actually our team sitting in one of the rooms in JSS and building the system, directly talking to the actual users, like the people sitting at the registration desk or in the pharmacy, actually sitting with them, asking what problems they are facing, observing what problems they are facing, and then building features right there, right? And lastly, we also learned that build a product which is more configurable and that can be changed, that can be molded according to the requirements, without making any code changes, right? So configurability is the key, right? The easy you make it for the users, the better the uptake, right? And yeah, build your ecosystem. You have to have local support at any place. You cannot sustain a product, providing services everywhere. You can just build something and then you have to hand it over. So that's all I had.
So Dr. Akhil and Dr. Mithun both mentioned ABDM. How many of you have heard about ABDM? Okay. How many of you know the full form of ABDM? Okay. So yeah, there are people who know about ABDM. And yeah, so that's going to be our next talk actually, specifically on ABDM, because you must be wondering, right? There are so many DPGs, there are so many systems cropping up around in the ecosystem, working with grassroots communities, but how will this all get integrated together? And that's what ABDM is about, and of course more than that. So I would like to invite Himanshu Burad. Himanshu is an engineer turned public policy professional. Currently he is working as an officer on special duty to the mission director ABDM at the National Health Authority. Prior to this, he worked at the Union Health Ministry on various projects in the COVID War Room and the launch of the PM Ayushman Bharat Health Infrastructure Mission. He will share how ABDM, which is the Ayushman Bharat Digital Mission, creates an ecosystem to enable private players to integrate healthcare DPGs and DPI. So over to you. Just set up the presentation.
Good afternoon, everyone. Thank you, Shaliza. I'll not take much time of yours because whatever the earlier speakers have alluded to, it's basically building that ecosystem, and I want to give you the overall objective with which we have begin this journey of Ayushman Bharat Digital Mission, which is, of course, I would say, started much later than what Amrit or Bahmani has done it. So yeah, Ayushman Bharat Digital Mission, earlier known as the National Digital Health Mission, is basically building the national digital health ecosystem, which earlier speakers have also alluded to. So building for 1.4 billion people. Just to give you the scale with which the government of India has been working with the open ecosystem, started way back in Aadhaar 2009, which is now the basic core construct on which the entire DPI ecosystem in our country is running. So Aadhaar then built on some value-added services, that eKYC, then e-sign. Now UPI is something which we all are well aware with. All of them are DPIs, which are basically building that country-wide ecosystem level scale products which we are using on a daily basis. ABDM is just another, you can say, next set of innovations which we want to continue in this journey of India Stack, which is which you would know. So ABDM, what it is trying to do is taking the DPI approach, which has been successful in the finance ecosystem and other ecosystem, and bring it into the healthcare domain as well. We have all heard the challenges which you have said, lack of doctors, lack of resources, all those things. So can we bring the entire ecosystem together and solve for those inefficiencies, so that if, let's say, somebody is solving for the EMR solution, somebody is solving for the citizen part, nobody has to reinvent the wheel again and again. Everybody should do what they are doing at best, right? So that's the broad objective with which the ABDM is working, the open ecosystem where everybody can come in, plug in their solution, interoperability is the core construct with which we are working. So if Amrit can talk to Bhavani, that solves our problem. So that Amrit can focus on a very particular region where they are located. So I saw the map, they are not there in Madhya Pradesh. There was a big hole in the map of India. If Bhavani is there, they can talk to each other. That's the core construct with which ABDM goes about. Now, if I have to make these systems talk to each other, I need a common identity. Can they talk to each other the language, right? So if let's say Shelja visits Amrit solution and next she visits Bhamni solution, can both solutions identify her as a single individual? In digital ecosystem, we have to assign a single identity to each and every stakeholder. That is where the centralized nature of ecosystem helps, and that's what ABDM is also trying to do. It is setting up the core registries, which would be unique across the ecosystem, and every solution can leverage it. So ABHA, which is the citizen identifier, can be the common identifier for citizen when they move across systems, right? So that is registry for professionals, facilities, and citizen. I'll touch upon them in the subsequent slides as well. Eventually, can we achieve a paradigm shift? Because if there are efficiency in the system, if there are redundancy reduced, everything is falling in place. So what we like to encapsulate is at the bottom, trusted actors, giving them identity. Verifiability is something which we have already seen in the Aadhaar eKYC Aadhaar bit. So if we can bring that, and digital connectivity, which the rest of the parts of the government are solving. So taking the mobile connectivity to the remotest part of country, BharatNet, all those things can solve for this, and can we achieve a interoperable health ecosystem just like a financial ecosystem. So brief about vision of ABDM. It was launched in 2021 by the Honorable Prime Minister from the ramparts of Red Fort. Prior to that, it had a 1-year pilot period from 2020 to 2021 during the peak pandemic period. Its motto and objective, I believe it's the very strong principle it lays out for itself, that we have to have a universal health coverage. Although ABDM in itself does not deliver any service, but they want to achieve that universal health coverage through digitization as a mean. So anybody can use the ecosystem, open ecosystem, which we are all here assembled for the DPG dialogues. But the core construct is the bottom bit: security, confidentiality, and privacy. That, in the light of DPDP Act, has become the core for every citizen. Although we may agree that they are not yet aware, but we will reach to that point. So we have to build our systems in a way that every solution is taking these things into consideration. I'll not mention much about this slide, but I want to leave you with this slide. This is the entire health stack for ABDM, and the way to read it is from bottom to top. So the core registries, or the cross-domain digital public goods, which we like to call Aadhaar, eKYC, those services we leverage in our registry. So for example, a doctor wants to register an HPR, the doctor will eventually sign through eKYC mechanism. They will use their Aadhaar to register on the ecosystem, right? So these registries then are talking to the gateways, the 3 gateways which we have: the Unified Health Interface, which gives you the interoperability in services. So I can avail teleconsultation, book ambulance booking from one app to another without switching from one app to another. The second bit is the information exchange, health information exchange and consent manager. It is solving for the interoperability in health data. And the third, which is completing the loop. So once you avail the service, you share your data, and eventually you will raise the claim for that. That's where the National Health Claims Exchange bit comes in, where we are basically talking to hospitals, we are talking to the insurance company, we are trying to create a unified claims platform. And for us, this has been now the biggest driver for the entire ecosystem, because that's where, for the lack of better word, the health financing runs through in the entire ecosystem. The services in the health data exchange does not have that finance element built into it. So health claims exchange is something which we are very bullish on. Now the layer on top, which is where the solutions like Amrit and Bhavni sits, they are HMIS and the LMIS for us, and they are integrating with these gateways where they can provide those services. So the overall objective with which NHA is also working is at the core is public-private participation, and by private it's not just the profit sector making the private bit, but also the non-profit as well as the open community part of it. So NHA at its core is maintaining these registries, protocols and gateways. They are building these protocols and gateways which can be availed by anyone, and you folks, the startup community, the healthcare hospital community, the DSC community, everybody can build that service, because after the 1991 reforms, everybody realized that the government is not very good at providing these things to the customer. So customer side, customer facing applications, be it hospital, be it citizen, has been given to the private sector to take care. To briefly mention about the intended benefits to the stakeholder, which we have been mentioning about it, but we would just want to put it down in terms of all the three stakeholders for which are crucial for us. ABDM, we usually tell you that it is a patient-centric ecosystem. We want to bring the patient who right now is out of the entire conversation. We want to bring that patient through the consent, through the privacy layer back into the healthcare domain. They can take control of their health, they can take the decisions, and given the rise of NCDs in our country, this becomes more and more important. Healthcare providers, I think the previous speakers have already touched upon it, clinical decision making, because these are the tools with which they are leveraging to make those decisions. ABDM by itself will not do this. These are being benefits which are accruing to the stakeholders through these solutions. So they are already doing on it. On the policymaker side, we want to achieve a level where public health monitoring, which is right now running in silos. If you have been in the ground, you would know that there are multiple programs which are running in silos, and at the last level there would be 50 apps which an ASHA or ANM is running. So we want to, at some point in time, we want to have an ecosystem level. This is the last bit I want to leave you with, is the numbers. Where are we as of now? So 67 crore ABHA have been created, which is 1 in 3 if we consider 150 crore, let's say. So 67 crore people have ABHA numbers. Facilities, we are 3.4 lakhs. Out of 3.4 lakhs, we have 1.32 lakh facilities which are using ABDM enabled software. In this, again, you will have facilities which are using both Amrit and Bamni. And these facilities have collectively linked 43 crore records against the above citizens. Similarly, doctors and nurses, right now we have 4.82 lakh nurses and doctors. The solutions are right now 200, but in the ABDM sandbox, you all can have a look at the ABDM sandbox. We have around 1,000 solutions in pipeline who are trying to integrate with ABDM and trying to offer those solutions to the customers. The last is I would ask every one of you to look at this specific aspect of scan and share, which right now we have reached out to almost 15,000 government hospitals and trying to bring the efficiency at the government hospitals. What it is, I'll not tell you. Go out, do some research and thinking about it, and I'm sure you will be amazed the scale with which this particular component of ABDM is running. And this is, again, mind you, a small part of HMIS. There are record linking and other, but this is small registration part of HMIS, and it is saving almost 2.5 crore, I don't know the gender neutral term, man hours for the country. This is the scale with which we are trying to solve for it. Microsites is something, another initiative which we are running, and maybe a speaker after me will touch upon this. So yeah, this is in nutshell, lightning. I hope it helped for you. Yeah, this is me. Thank you.
Okay, so our next speaker is Bhargava. Bhargava is an IT services professional turned banker turned entrepreneur turned DPG DPI advocate. Lot of shifts, but good to know that. In the previous stint at eGov Foundation, he was part of the core team which took up the adoption of Digit. And so on top of it, a lot of other services have been built, if you all know about Digit. He is currently passionate about solving for the health financing use case using the DPG and DPI. I would like to invite him over for the talk. So he'll be covering about the whole claims part of it.
Thank you very much. Himanshu set me up very nicely and sweetly by talking about health claims exchange. You would have seen that it's one of the core components of the entire ABDM architecture. We'll quickly talk about what HCX really does. Now imagine Lakshmi, a 45-year-old mother of 2 children, has suddenly had a heart attack, right? So what immediately happens is the entire family, everybody in that house are really worried about her, and they want to get her to the best hospital, they want to get an ambulance, they want to get there, they get her there, they don't know what the treatment guideline is going to be, what the doctor is going to say, they don't have a clue about any of these things. At the same time, they also have to contend with how will I pay for it? What is my eligibility? If I have an insurance, what am I entailed to? If it's a public insurance, PMJY, what am I entailed to? They don't have any clue about it. And there is also a worry, common Indian worry, that will this medical crisis leave me in poverty, right? That's where the millions of Indians at this particular point in time are. Now, why is this as a problem as a health financing ecosystem is? We would ideally like to think, we would ideally want to sympathize with Lakshmi, but it's not just Lakshmi who has this problem. There's a patient who has a bunch of challenges. The challenges which patient has is that they don't have, there's a very inconsistent claim experience, right? I mean, if I go to a large hospital, the claim experience is different. If I go to a public hospital, there's a different claim experience, and it's very inconsistent. And then there is transparency issues. Now, I don't know what I'm eligible for. I don't know where my claim is stuck. All I'm seeing is I'm going and stuck in this line before this hospital saying, when are you going to pay me? When are you going to get me discharged? Or when are you going to start my treatment? That's when I'm stuck, right? If I look at the provider side of it, the provider is also caught in a different sort of a problem. The provider is thinking that a provider typically is catering to close to 40 different insurance companies, a large provider. If you go to a Medanta Health City, they typically have 40 empaneled health insurers. So each one of them have their own systems. There's huge variability of claims for them as well. And for them, there are other problems. There is manual processing of all of these claims. There is again low trust. There is this issue of, will this claim ever come through? Will this get approved? How much money will I get? What money will I get? And then there is also their cost problem, which is what is a long receivable cycle. Some of them may get a receivable cycle of 60 days. Some of them may have 90 days. All of that causes them a hassle. Then you have the payer who has his or her own financing challenges, right? Now, these guys don't know who they are connecting with to get this claim processed, right? They have a huge amount of manual and error-prone systems right now. There's a lot of fraud which happens in all of this. And then they have their own transparency issues here because you really don't know whether there's a fraud happening. You keep coming across somebody doing insurance fraud, somebody saying it's actually not a patient, but somebody is claiming, somebody is making money. What's happening? We don't know, right? And then there is a cost of processing for the payer as well. And finally, the policymaker is absolutely clueless because there is no observability of any of this data at any point in time. Who is walking in, what insurance, what can I govern? No idea, zero clue. The IRDAI gets all of this information as a post facto data, but there's nothing they can do in real time to help solve for any of these things. So where does HCX really come in? HCX is nothing but a bunch of common specifications. What it does is it enables a seamless exchange of data between all of these ecosystem players I talked about. We're talking about policymakers who can immediately manage eligibility criteria, manage grievance redressals, they can observe service quality. When you talk about the patient can understand what their eligibility is. They can see where their claims are stuck. They can track the status of the claim, they can give consent, they can raise grievances. Then you have the payer he or she can also see what are they signing up for when a patient is walking into a hospital. They have visibility. And the hospital, most importantly, knows, is this a legitimate patient with a legitimate insurance and what is the kind of eligibility they have. All of this gets covered thanks to HCX. Now, HCX is a digital public good and takes a layered approach. At the bottommost layer, what happens is there is an open source community which kind of builds these protocols. It's global, it's multiple use cases, the use cases are constantly evolving, it's open source. Now on top of it, what Himanshu mentioned is a network, HCX network, which is where somebody like NHA operates the national switch, which is the NHCX which he talked about, which is a very, very core component of driving the specifications into the usage which we are talking about. And then on top of it, again, as Himanshu had mentioned earlier, you have all the ecosystem players. You have hospitals coming in, integrating with them, service providers integrating with them, providers integrating with them, and so on and so forth. Essentially, the idea is very simple. It's an open community-driven protocol. Design principles are, it's open so that anybody can join in and contribute. It's evolvable and extendable so that you can continue innovations and it's future-proof. It's interoperable so that all kinds of systems can come on, play and talk. It's minimalistic and inclusive. It's unification over standardization because there is harmonization required. And then it balances data privacy and security. The most beautiful part of HCX is data blind. The switch can't see what you're sending to it. And finally, we are talking about unbundled nature of it. There have been 200 plus volunteers working over 46 months to build this. We've got 5 versions of HCX already live, and NHA is running the switch, right? So the use cases it caters to, from OPD to IPD, involves cashless as well as reimbursement. So finally, the point is, if a Lakshmi, unfortunately, has to have a heart attack and her children are there with her, the family and Lakshmi should not worry about where is the money going to come from, what am I eligible for, they should be focused on giving care to her. Now, at this point in time, it is just insurance we're talking about. But the imagination is that any of us, the millions and billions of citizens of this nation, can walk into any kind of facility, health facility, whether it's a public facility, government hospital, private hospital, pharmacy, if you're talking about diagnostic center, whether you're talking about palliative care center, you name it, or preventive centers, any one of these centers, they can walk in with a financial instrument. The instrument could be a PMJY insurance, it could be a private insurance, it could be a voucher. Let's say Himanshu likes me and says that, boss, you need to take care of your health, and he gives me a voucher. So I go with it. I can claim it as long as that facility is HCX enabled and the voucher is HCX enabled. You can, without any problem, access financing options and walk away taking care of your health. That's the vision which we envisage in HCX. Thank you for the opportunity. Please join us and contribute.
Thank you so much. I would like to call upon our next speaker, Pallavi Jain. Pallavi Jain is a practitioner in the social development sector with over 10 years of experience of working in more than 15 states across India and internationally. She is currently leading the Youth Ownership of Digital Health Youth Project at Path India Country Office, New Delhi. Pallavi will be talking about the youth community and how a community-led approach can enable implementation of all of these digital systems that we were talking about before. So over to you, Pallavi.
Great. I hope you all can hear me and I'm loud enough in case I digress a little from the mic. So, I'm Pallavi Jain, and thank you so much, Shailaja and the team, for this opportunity. So, in the last about 30 minutes, we've heard about different interventions, EVDM, HCX, Harmony, so many other things. Many of these initiatives were either scaled up during COVID or after COVID. Many of these ideas emerged at that point. So I'm going to slightly trace back to COVID. So you prefer that? Perfect. No worries. Great. So if we quickly race back our minds to around COVID and talk about healthcare, we saw an overburdened system across the world. We also saw people and communities come together, especially when we talk about the youth. You might have seen many pages on Instagram, YouTube channels, youth coming and trying to cut down on the misinformation that was being spread. How can we as a community provide access to those resources? So that is something which was happening on one end. What did this do? This basically highlighted on the prowess of youth leadership and their ownership over the health sector. Parallelly, we could also see the need for infusion of technology and digitization in healthcare. I'm not saying that it is only after COVID or during COVID that digitization and infusion of technology came into healthcare, but I would say it's the adoption which sort of just picked up pace from that moment onwards. And when we saw these two themes sort of emerge and come together, the youth, their ownership, and the need for accelerating infusion of technology in healthcare. Us and many of our partners, we have IIC in the room, we have a bunch of our youth ambassadors and the team also here. All our partners had a very similar thought, that how can we actually create a platform where we can bring together people, where we can bring together, young folks who can actually take up digital health in a big way. So, so Youth was formed in July of last year, and our aim was to bring together a community which can actually help connect, create, and collaborate people who are working in digital health and in allied sectors. Now, you would say, who's working in digital health? Today, pretty much everybody is working in digital health, whether it is, medical, whether it is doctors, it is health practitioners, it is technologists, we have entrepreneurs, we have, people from policy and research. I, by the way, don't come from a health background. I come from a communication background, but I'm also working in digital health right now. So this really became like a melting pot of, people from different backgrounds coming together to really accelerate digital health. So our aim is to create this platform with the overall goal to create future digital health leaders who can create opportunities to firstly interact with one another, and also to bridge the gap. And the gap that I'm talking about here is that we all have been a part of the industry, right? But you take up any industry, what really happens? It's the more experienced and the more senior people, who are always out there, who are representing. I'm very glad to see that in this room, the 4 presentations that we've had so far have all been led by, the younger folks. So that's very, very encouraging. This is the paradigm shift which is happening now. So we are a community of, young practitioners under the age of 35. So how can we, right from a very early start, give them the right platform so that by the time they are, in their mid-management, they're already well connected, have the right access to knowledge when it comes to digital health. So I would say in the last about, say, maybe 15, 16 months of our existence, we are over 800 member strong community across 25 countries. In over 70 cities globally, and over 53% of our members identify as women. We have a lot of collaborators who have a shared vision, and many more who think alike. So we sort of, the whole idea is about collaboration and coming together. Our 3 pillars are community engagement, capacity building, and networking, and these are underpinned by our objective of creating future leaders in digital health. Keeping that in mind, keeping the fact that we want to create leaders, build capacity, at the same time enhance knowledge of people who are a part of this ecosystem, we essentially have 7 different initiatives. I will very, very quickly touch upon them. We have our ambassador program. So basically we have 3 monthly cohorts where our members of youth community come together and actually help in running the youth program, whether it's different initiatives, it is coming together and thinking of what projects can we take up, so on and so forth. We have Youth Charcha, which is our monthly webinar forum. We have Youth Dialogue, which is our podcast series. We have Discovery, where we basically take our our community to centers of excellence around health, so they can actually see what really is happening on ground. They can interact with the experts. We also have Youth Adda, which is again a monthly platform where our global community comes together, and it's like an open mic. You can come and talk about anything around digital health. So that really trying to create that space where people can come and talk about collaborations. So one of the previous speakers talked about the need of creating an ecosystem. We have a lot of things which are happening right now, but how can we have discussions around those topics? How can an entrepreneur who's probably looking, finding a technologist, or looking for somebody to vet his idea, how can we do that, right? So we are really trying to bridge the gap and create that ecosystem. We're also coming up with a mentorship program where the young and the mid-level management students or professionals can be mentored by seniors, so that they can carve out their solutions better and address the challenges that they're facing better. Yeah, we are there on a bunch of social media platforms. You can a lot of our knowledge building resources are open source, so you guys can go and access those. So what lies ahead? What really is the aim of youth? What are we trying to build? If I look at a future. So, we talked about, how things are operating in silos. We talked about the need for people to come together. We talked about, conversations to happen right at the micro level also. So these are the things that, we also have at the forefront. We have in mind, and this is the way in which we want to take youth forward. One of the things that we want to do is that, how can we create youth to be a self-sustaining entity? And by that, I just don't mean funding, but how can it be run in a self-sustainable manner? The whole idea is that, youth is a democratic, we follow a democratic approach. We follow the approach of communities of practice, right? So youth actually is existing today because of the shared passion by 800 plus people, right? How can we actually bring in their expertise together and, hold enough interest that they can carry forward this, community. So we are planning to open, city-wise chapters. We are planning to, be the face of digital health, and in the end be able to create a forum where we are, a go-to shop, if I can say, for digital health. Again, in interest of time, I'm just going to, leave us with the last thought that, if you are under 35 years of age, you are working in digital health, or, want to learn a bit more about this space, you can get connected with us. It's free membership. If you're interested, the youth stores are always open for you. Thank you so much.
Thank you, Pallavi. So unfortunately, we are a little short on time, but we can take a few questions, maybe 2-3 questions, and and you can also say the name of the speaker that you have the question for. That would be helpful. Any questions in the room? Yeah, please go ahead.
I think any of the initial few couple of speakers can actually answer. I wanted to ask about interoperability. So when, especially we are working with governments which are, let's say, if I'm sitting in Delhi, let's say I'm working with the government of Andhra Pradesh and giving them an open source system of managing electronic healthcare records. Or let's say, I think one of the speakers mentioned, you mentioned about working with the government of Nagaland taking up your solution. So what are the challenges you face with respect to interoperability, with respect to the fact that they are willing and have trust to put their data onto this system? Like what exactly is the communication you have with them? Maybe something along those lines.
Okay.
And this is coming from me, if you know about OpenMS, so I worked briefly with them, which is being developed as DPG. So and we faced a lot of these challenges. I was working globally to governments. Never mind. Yeah.
Okay, maybe, Dr. Akhil, you can take it up.
So, when ABDM came in, a lot of those challenges actually went away. Right? Because, ABDM is actually a mandate almost, for all the public facilities. And ABDM is basically an interoperability network, right? So if you are connected to ABDM, you are compliant with ABDM, you are already interoperable because it lays down standards like HL7 and FIRE that you need to follow. And then you have your SNOMED codes that you need to, because India is a member country for SNOMED, you get to use SNOMED dictionary for free, right? So which is basically a terminology service. Okay? So basically, how a terminology service works is basically, if you call paracetamol in India, it's called acetaminophen in North America, right? And both of these things mean the same, right? So if you are taking your records to some other area where a local word or a different word is used, right? You are not misunderstood. They are not confused what you are saying, right? So it says that, okay, these two things are the same. So this is basically interoperable, right? And since in India now we have ABDM, a lot of those challenges went away. But we have faced these challenges in other countries. I'll give you an example of Bangladesh. We actually had to build a complete shared health record system for them, which is very similar to what ABDM is. ABDM is consent based,
that was not consent based, right? Because it was their government's priority, however they wanted it. So we had to build that so that we can establish that framework. We had to build a master patient index, a facility registry, a patient registry, everything. And then we rolled out BAMNI over there. So sometimes you have to find out solutions. You have to convince them that if you want this is the outcome that you want, then these are the following routes that you have to go through.
Okay, I learned the new snowbike thing, and thank you. This is great. Each of the speakers gave a great lightning round.
Okay, thank you. Rahul, you had a question? You had your hand up.
Yeah, I had a question for Mr. Himanshu. I think one of the things in one of the slides where you talked about who the beneficiaries are and what kind of things that they get. At the bottom, you had information about what kind of policy information that we'll be getting. So can you talk a little bit about that? Because I'm not sure how sort of the consent-based data sharing mechanism fits into sort of population scale data that the government needs to be able to make some of those decisions.
So see, there are two aspects to it. One is the PII data, which you are referring to, and this is entirely consent-based sharing, which is usually routed through the second gateway, which is the Health Information Exchange and Consent Manager. The decision making which has to happen by the policymaker need not be personally identified, except in rarest of rare case, which is, let's say, the disease which are already notified by NCDC, where you have to submit the line listing of the data, which in COVID it was the case. But as far as the regular disease are concerned, one of the component which we have not yet, I have not yet shared, but you folks can go and read about it, is it's mentioned in the National Digital Health Blueprint. It says about anonymizer as a service. So what we envisage is, for example, the solutions which we have with the ready example, let's say of BAMNI and Amrit. The anonymizer as a service will go and sit at all the integrator level, and we will only have the anonymized data which will flow from these solutions. And as of now, it's not just HMIs. Right now we are integrated with RCH, we are integrated with Anmol, Nikshay, all the government programs. So all these government programs coupled with the HMISs will send the anonymized data, and that can be aggregated at a state level to give the state a visibility at a maybe at their level, and they can further percolate it to district or block level. Completely anonymized, completely aggregated, which basically gives the patient the, I would say, agency that this data is not PII, one, and second, also complies with the DPI. Additionally, we will be coming out with something around this entire architecture. Right now, this solution is not in place for a simple reason that right now as a country we are still struggling to get structured data. Everything which we have talked about right now, the entire bit will only be possible if I have structured data. Right now I don't have structured data. Even in the ABDM construct, all the solutions, they're sending me PDFs which I can't process, and even if I process, the removal of PII from those PDF is a very difficult task. Right? So we are not dealing with those aspects, but gradually as this ecosystem matures, as we'll have more structured data coming in, we'll be rolling out this component which is anonymizer as a service, and then those things will be possible at a policymaker level.
Okay.
Can I ask a follow-up?
Can we take this question offline?
Thank you.
Thank you so much. Thank you everyone, all the speakers, for taking out the time and sharing your insights with the entire group. And yeah, please feel free to catch them after the main plenary also, not now because we have to head to the main plenary and I don't want you guys to be late. And I also have to go because I'll be anchoring there as well. So yeah, so let's all move there. But yeah, do catch up with them and ask all your questions, or in case you miss catching up with them, just reach out to me or the C4GP team. We'll be more than happy to connect you with the speakers. Thank you so much.